following a heart surgery. The diagnostic tests that we perform to identify the presence and the degree of coronary artery disease among women are similar to those that are employed in men. We perform the lipid profile, which measures the total cholesterol, the HDL, the LDL, and the triglycerides. As we know, these are the major risk factors for heart disease. Similarly, low thyroid or hypothyroidism can lead to cardiovascular symptoms, and hence we measure the TSH. We screen women for diabetes by using fasting blood sugar and hemoglobin A1C. Similarly, vitamin D and folic acid deficiencies have been associated with coronary artery disease, and hence measuring these vitamin deficiencies and correcting them will help to reduce the risk of coronary artery disease. Electrocardiogram is limited in terms of diagnosing coronary artery disease, but nonetheless, the electrocardiogram can help us to identify heart enlargement or the presence of old heart attack. Echocardiogram is a very important, useful tool in terms of looking at the structure of the heart and the blood flow within the heart chambers and the function of the heart valves. Echocardiogram helps us to identify the presence of congestive heart failure and reduced heart function. Nuclear stress test is extremely useful in ruling out the presence of a significant coronary artery disease. However, in women, breast shadow may overlap the heart, thus creating artificial defects which may interfere with the interpretation of the results. Coronary CT angiography is a very useful tool in women with low risk factors to rule out coronary artery disease. If the CT coronary angiography reveals normal coronary arteries, then the risk of a significant heart disease is less than 2%. A PET scan, like the nuclear stress test, looks at the blood flow to the heart muscle and also looks at the viability of a heart muscle if there is a question of a previous heart attack. Finally, coronary angiography or cardiac catheterization is considered the gold standard in diagnosing the degree and the extent of a coronary artery disease. Management of heart disease among women requires a more aggressive approach. A heart-healthy diet is a must in terms of reducing the risk for heart disease. Increasing physical activity, smoking cessation. By reducing smoking, you can almost reduce the risk of heart disease by 36%. Weight reduction will enormously help in reducing your blood pressure, in reducing your need of medicines for diabetes, and also reduces the wear and tear on your joints. Cholesterol management with nutritional supplements, diet, and drugs is of great significance in reducing the overall risk factor for heart disease. Similarly, cardiac rehabilitation is an important element in the management of heart disease. Aloha is a 5-step approach where first we assess the risk of heart disease. Number 2, lifestyle approaches are recommended for all women. The other cardiovascular conditions such as hypertension, diabetes, lipid abnormalities must be addressed simultaneously. Highest priority for interventions in high-risk patients. High-risk patients must undergo nuclear stress testing and cardiac catheterization to evaluate the presence and the significance of a coronary artery disease, and appropriate steps must be taken to reduce the risk of a heart attack or subsequent heart failure. And avoiding therapies that have not been shown to be of any benefit in the long run. The goal of lipid management is to reduce the total cholesterol to less than 200 mg/%, keep the HDL above 40 mg/%, and reduce the LDL to 70 to 100 mg/%. As I told you, if you are in the high risk category, then the LDL should be below 70 and the total cholesterol should be below 160 mg/%. Similarly, reducing triglycerides below 150 mg/% would also be beneficial. Some of the supplemental agents that you could consider would include fish oil, flaxseed, which are omega-3 fatty acids, which help to lower the LDL cholesterol. Niacin has also been shown to reduce the LDL cholesterol and improve the HDL cholesterol. Benefiber has been shown to reduce the cholesterol by 10 to 15 points. I already talked about replacing folic acid and vitamin D3 if these are noted to be deficient. Here's a study looking at 11 clinical trials of statin treatment among women with known heart disease. There was an overall reduction in the total cholesterol by 21%. There was a 36% reduction in the LDL, and there was a 26% reduction in the triglycerides. Let's focus on hypertension in women. The ideal management of hypertension in women. It involves maintaining ideal body weight and healthy eating plans with weight loss, diet rich in fruits, vegetables, low in dairy products to reduce the blood pressure. Salt reduction will greatly reduce the blood pressure, especially among African American patients. Increase of physical activity would also help to reduce the blood pressure. Alcohol intake should be limited to no more than 1.5 ounce of liquor per day. Physical activity should be an important and integral part of management of heart disease among women and men. If you were to increase your physical activity for 20 to 30 minutes, 3 to 4 times a day at 5 METs, which is 5 times your normal walking speed, then you can reduce your risk of heart disease by almost 50%. That alone should be an inspiration for you to start getting active. Diabetes and heart disease management in women. The goal here is to have a hemoglobin A1C of less than 7%, but if you already have a heart disease, it should be less than 6.5. On the other hand, if you have diabetes, you are already considered to have coronary artery disease even before any symptoms or any tests are considered. The fasting blood sugar should be less than 100 milligram percent. Calorie restriction will go a long way in not only helping you to manage your sugar better, reduce your pills and insulin, but will also help to reduce your triglycerides, weight, and the subsequent complications related to diabetes. Along the same lines, weight control, exercise should be an integral part of your management of diabetes. If you have diabetes, you should be closely monitored not only by your primary care physician but also by your endocrinologist and cardiologist, working in concert to make sure that the multiple risk factors are significantly reduced. Hormone therapy. Hormone therapy has undergone a seesaw cycle as to its benefit in terms of either reducing coronary artery disease or increasing coronary artery disease. The risks of hormone therapy are far more compared to the benefits we get from hormone therapy. The risks related to hormone therapy are venous thrombosis, gallstones, breast cancer, bleeding side effects, heart disease, stroke, dementia, pancreatitis, and possibly ovarian cancer. However, hormones do play an important role, especially in postmenopausal women, in terms of controlling vasomotor symptoms, reducing osteoporosis, reducing vaginal atrophy, reducing the risk of colon cancer, and skin preservation, and also helping patients with depression. Here is a general consensus about hormone therapy for women and heart disease risk. Estrogens plus progestin is associated with a small but significant risk of heart disease and stroke. Estrogen without progestin is hormone therapy. General consensus statement is estrogen plus progestin is associated with a small but significant risk of coronary artery disease and stroke. Estrogen without progestin is associated with a small but significant risk of stroke. All hormone preparations should be limited to a short-term menopausal symptoms relief. Cardiac rehabilitation is an important aspect of management of women with heart disease. Most physicians are happy to prescribe pills and have patients come on a regular basis, but very little emphasis paid on rehabilitation of the patient in terms of diet, exercise, and lifestyle modifications. Hence, cardiac management among women should be a team approach, a multidisciplinary approach if we want to maximize the benefits and reduce the risk factors for heart disease. Women are less likely to stay in cardiac rehabilitation program unless the medical professionals underscore the significance of ongoing cardiac risk factor modifications to minimize the risks. Prevention of cardiovascular events, either primary or secondary, is related to other underlying conditions. Aspirin has been found to be useful in reducing the risk of heart attack among men and women. If a person has a history of a heart attack, then use of beta blockers have been shown to reduce the risk of subsequent heart attack or sudden death. Similarly, patients who have enlarged heart or congestive heart failure, or if the heart function is less than 40%, then use of ACE inhibitors have been shown to improve symptoms and improve mortality. Hormones and antioxidants have questionable benefits in terms of modifying the risk factors. A few words about prevention of heart disease using aspirin. Using aspirin 75 to 162 milligrams or clopidogrel or Plavix in patients with high risk may be beneficial in terms of reducing subsequent cardiac events. In the intermediate risk group, we may consider aspirin therapy 75 to 162 milligram percent if women have history of high blood pressure. However, we should also consider the risk of gastrointestinal bleeding when these patients are treated with aspirin. Hence, we need to balance the risk versus the benefit in the intermediate risk group. In the low risk group, aspirin has not been shown to benefit, even though it has been found to be beneficial in men. Here are some useful resources: the AmericanHeart.org, HeartForWomen.org, or WomenHeart.org. In conclusion, heart disease is a number one killer among women. More people die from heart disease, more women die from heart disease compared to many other conditions such as cancer, stroke, or kidney problem, or similar to those in men. However, the clinical presentation of heart disease poses challenges not only for the physicians but also for the patient. Nonetheless, aggressive management of risk factors and proactive lifestyle changes, smoking cessation, exercise, and weight reduction can make the difference between leading a heart healthier lifestyle versus having significant heart disease. Well, the choice is yours. Here you have the roadmap to dramatically reduce the risk of heart disease. I am Dr. Nik Nikam. Hopefully, this presentation has increased your awareness of the magnitude of the heart disease among women and perhaps has inspired you to implement simple changes in your lifestyle which can have a profound effect in the long term on reducing the risk for heart disease. Why not share this with your family members or friends and make a difference in their lives? Thank you for listening. I am Dr. Nik Nikam. Have a good day.